Morning class. So today we're going to be going over Chapter 36, Patients with Special Challenges. Special patient populations applies the fundamental knowledge of growth, development, and aging and assessment findings to provide basic emergency care and transportation for a patient with special needs. Patients with special challenges, healthcare implications of homelessness, poverty, bariatrics, and technology dependent. Hospice / terminally ill, tracheostomy care / dysfunction, home care, sensory deficit loss, developmental disability. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Special considerations in trauma, pathophysiology, assessment and management of trauma in the cognitively impaired patient. Introduction. Today, more people with chronic diseases live at home, shorter hospitalization, improvements in medicine and technology, patients with special challenges, patients with diseases resulting in altered body function, patients with sensory deficits, geriatric patients with chronic diseases. Some patients depend on mechanical ventilation, intravenous pumps, and other devices. Do not be distracted by the equipment. Remember, always treat your patient, not the monitor. Focus on the patient, what the patient is telling you, what the patient looks like. Intellectual disability, developmental disability refers to insufficient development of the brain resulting in some level of dysfunction or impairment. Can include intellectual, hearing, or vision impairments. Intellectual disability results in the inability to learn and socially adapt at a normal developmental rate. Possible causes, genetic factors, congenital infections, malnutrition, environmental factors, fetal alcohol syndrome, traumatic brain injury, poisoning. Slight impairment, slow to understand or limited vocabulary, behave immaturely compared to peers. If severe, may have inability to care for themselves, communicate, understand, or respond. Rely on patients and family members for information. Patient may have difficulty adjusting to change or a break in routine. Patients with intellectual disabilities are susceptible to the same diseases as other patients. Autism spectrum disorder, pervasive developmental disorder characterized by impairment of social interaction, severe behavioral problems, repetitive motor activities, impairment in verbal and nonverbal skills, may be hyper or hyposensitive to sensory stimuli. Wide spectrum of disability. Patients have difficulty using or understanding nonverbal communication. Do best with simple one-step directions. Affects males 4 times more than females. Typically diagnosed by age 3. Older adults may not be diagnosed. Patients may have medical needs similar to their peers without autism. Move slowly, stay calm, and perform physical examinations from distal to proximal. Remember, always talk to your patient, always let them know what you're doing, especially people with autism. They might be more afraid of you getting close to them and touching them. Always talk to your patient and let them know what you're doing. Down syndrome, a genetic chromosomal defect that can occur during fetal development, results in mild to severe intellectual impairment. Increased maternal age and family history are known risk factors. Associated physical abnormalities, round head with flat occiput, enlarged protruding tongue, slanted wide set eyes. Increased risk for medical complications, 40% may have heart conditions and hearing and vision problems. Intubation may be difficult due to large tongues and small oral and nasal cavities. Mass ventilation can be challenging. Jaw thrust maneuver and nasopharyngeal airway may be necessary. Management of seizures is the same for any other patient. The anteroaxial joint is unstable in approximately 15% of patients with Down syndrome. Increased risk of complications when they experience trauma. Patient interaction. It is normal to feel uncomfortable. Treat the patient as you would any other patient. Approach in a calm, friendly manner. Establish rapport. Normally ask the family members or friends how the patient is with strangers before you start getting close to the patient, talking to the patient. Know what their habits are as well with strangers. Introduce team members, explain what you're going to do, move slowly but deliberately, watch carefully for signs of fear, Make sure you are at eye level. Soothe the patient's anxiety. Establish trust and communication. As always, these tips should go with every patient interaction you have. You're always going to try and establish a rapport with the patient. You're going to establish trust and communication. You want to talk to your patient, let them know what you're doing, explain everything that you're doing so they understand. Brain injury. Patients with a prior brain injury may be difficult to treat. Talk with patients and family. Establish what is considered normal for the patient. Always try and get a baseline for anybody who's altered once you get on the scene. Do they normally know what day it is? Do they normally know who you are as a family member or friend? Any questions regarding patient's orientation, alert and oriented status? That may be normal for a patient. So always establish a baseline if you can. Explain procedures and reassure patient. Visual impairment, possible causes, congenital defect, disease, injury, degeneration of the eyeball, optic nerve or nerve pathway. Range and degree of visual impairment. Some patients lose peripheral or central vision. Some can distinguish light from dark or shapes. Visual impairments may be difficult to recognize. Patient interaction. Make yourself known when you enter. Introduce yourself and your team. Retrieve any visual aids and give them to your patient. Patient may feel vulnerable and disoriented. Describe the situation and surroundings to the patient. Transport considerations. Take cane or walker if used. Make arrangements for care or accompaniment of service animal. Patients should be gently guided, never pulled or pushed. Communicate obstacles in advance. Hearing impairment. Problems range from slight hearing loss to total deafness. Patients may speak. Many older people have some hearing loss. Always ask them if they have a hearing aid. Sometimes they turn the hearing aid off, or sometimes they don't have the hearing aid in. So those are good questions to ask as well. You guys might have to speak up on scene as well. Sensorineural deafness is caused by nerve damage. Conductive hearing loss is caused by faulty transmission of sound waves. Clues that a person could be hearing impaired: presence of hearing aids, poor pronunciation of words, failure to respond to your presence or questions. Communication with hearing impaired patient. Assist the patient with finding and inserting any hearing aids. Face the patient while you communicate. Do not exaggerate your lip movements or look away. Position yourself approximately 18 inches directly in front of the patient. Most people who are hearing impaired have learned to use body language, hand gestures, and lip reading. Do not speak loud or try lowering the pitch of your voice. Ask the patient, how would you like to communicate with me? American Sign Language may be useful. Hands-free communication. Speak slowly and distinctly into a less impaired ear. Change to a speak with a low-pitched voice. Provide paper and pencil. Use the reverse stethoscope technique. Another good one is, like they just said right here, provide paper and pencil. You guys can write stuff down and have a conversation that way. If a patient is extremely hearing impaired and you almost have to yell at the top of your lungs, because sometimes it does happen, and it might be easier to communicate with paper and pencil instead of it looking like you're yelling at your patient. So a couple sign language techniques. Hearing aids. Hearing aids make sound louder, maybe external or internal. Several types are available. Behind the ear, conventional body, in the canal, in the ear. Device should fit snugly. If whistling occurs, it may not be far enough. It may not be in far enough. So different kinds of hearing aids. I'm sure you guys have had grandparents or know some older people who have hearing aids. They all look a little different. So like I said before, ask if a patient has a hearing aid and ask if it's on as well. Sometimes they put them in and they forget to turn them on. Cerebral palsy, a group of disorders characterized by poorly controlled body movement. Possible causes: damage to the developing brain in utero. Oxygen deprivation at birth, traumatic brain injury, infections such as meningitis during early childhood. Symptoms: poor posture, uncontrolled spastic movements, visual and hearing impairments, difficulty communicating, unsteady gait. Considerations: observe airway closely and suction as needed. Do not assume intellectual disability. Underdeveloped limbs are prone to injury. Ataxic or unsteady gait makes patients prone to falls. Patient may have special pillow or chair. So gait, remember, is the way a person walks. So usually with cerebral palsy, you have unsteady or ataxic gait. Patient's not able to walk in a straight line. Pad the patient to ensure comfort. Never force extremities into position. Whenever possible, take walkers or wheelchairs along during transport. Be prepared for a seizure and keep suctioning available. So Spina Bifida, we've talked about this in a chapter earlier. Birth defect caused by incomplete closure of spinal column. Spinal cord is exposed. Opening can be closed surgically, but often leads to spinal damage. So here's part of the spinal cord grown outside the body. Associated conditions: hydrocephalus requires shunt, partial full paralysis of lower extremities, loss of bowel and bladder control, extreme latex allergy. So hydrocephalus is going to be water in the head, and they're going to have to put a shunt in to relieve some of that pressure because it's going to push down on the brain. Paralysis, inability to voluntarily move body parts, causes stroke, trauma, birth defects, may have normal sensation or hyperesthesia, may cause communication challenges, diaphragm may not function correctly, requires ventilator. So I'm sure you guys have always seen, at least in the movies, patients who are on ventilator. That's going to help breathe for the patient. Specialized equipment, urinary catheters. A lot of older people, especially who have, urinary problems, urinary tract infections, are going to have a catheter in. Tracheostomy tubes, colostomy bags, feeding tubes. Difficulty swallowing may require suctioning. Each type of spinal cord paralysis requires its own equipment and may have its own complications. Always take great care when lifting or moving a paralyzed patient. Ask patients how it is best to move them before you transport them. And this goes with every single patient. Anytime you're going to move a patient, you want to ask them, what's the best way to move them? What's the easiest way for the patient? You might have to carry them. Bariatric patients, obesity, person has excessive body fat, obese 30% over ideal body weight. Severe obesity, 2 to 3 times over the ideal weight. Imbalance between calories consumed and calories used. May be attributed to low metabolic rate or genetic predisposition. Quality of life is negatively affected. Associated health problems, mobility difficulties, diabetes, hypertension, heart disease, and stroke. Interaction with patients with obesity. Patient may be embarrassed. Plan early for extra help or equipment. Find easiest and safest exit. Do not risk dropping the patient or injuring a team member. So if you already know you're going to have an obese patient, you call for bariatric gurney, you call for extra hands. Sometimes the fire department will call for the truck company, get a few extra more bodies in there to help move the patient. Sometimes when they call into dispatch, I'm not sure if they still do this, but they can ask how much the person weighs. And that way they kind of get a head start, get another unit going for help moving the patient. And then always try and not drop the patient. Always communicate when you're moving a patient, especially obese patients. Treat the patient with dignity and respect. Remember, everyone should be treated with respect and dignity, regardless of their, regardless of the situation. Ask your patient how it is best to move him or her before attempting to do so. Avoid trying to lift the patient by one limb, which would risk injury to overtaxed joints. Coordinate and communicate all moves to all team members prior to starting to lift. If the move becomes uncontrolled at any point, stop, reposition, and resume. Remember, communicate with your helpers, with your partners. If you feel like your grip's slipping or you need to stop and take a rest, let them know. This is how people get injured. Always communicate what you're going to do with your partners. Look for pinch or pressure points from equipment. Deep venous thrombosis. Large patients may have difficulty breathing if you lay them in a supine position. Specialized equipment is available. Become familiar with the resources available in your area. Plan egress routes. Notify the receiving facility early. Tracheostomy tubes. Tracheostoma provides a path between the neck and the trachea, kept open by a plastic tracheostomy tube. Tubes bypass nose and mouth, temporary or permanent, for patients who depend on home automatic ventilators and have chronic pulmonary illness. Tubes are prone to obstruction by mucus or foreign bodies, emergency event. So it's kind of hard to see, but if you guys remember the little tube at the end of your BVM, you could actually disconnect the tracheostomy tube from the ventilator. They're still going to have the tracheostomy tube in their neck. You could actually put the BVM right over here, and you could bag the patient if you need to. If the ventilator stops working for whatever reason, you could go ahead and bag the patient. I believe one of you guys actually bagged somebody through the tracheostomy tube on one of your guys' ride-alongs. Dope mnemonic helps recognize causes of obstruction: displacement, dislodged or damaged tube, obstruction of the tube, pneumothorax, equipment failure. So the dope mnemonic is basically if the tracheostomy tube is not working right, you could think about these four issues that may be causing it as to why the tube's not working correctly. Common problems may be bleeding or air leaking around the tube. Tube can become loose or dislodged. Opening around the tube may become infected. Management: maintain an open airway, suction tube if necessary to clear a mucus plug, maintain the patient in position of comfort, administer supplemental oxygen, provide transport to the hospital. Mechanical ventilators used when patients cannot breathe without assistance. Possible causes: congenital defect, chronic lung disease, traumatic brain injury, and muscular dystrophy. If ventilator malfunctions, remove patient from a ventilator. Apply a tracheostomy collar designed to cover the tracheostomy hole. May not be available in pre-hospital setting. Can improvise by placing a face mask over the stoma. Caregivers will know how the equipment works. Apnea monitors, used for infants who are premature and have severe gastroesophageal reflux, have a family history of SIDS or sudden infant death syndrome, experiencing a life-threatening event. Used 2 weeks to 2 months after birth to monitor the respiratory system. Sounds an alarm if the infant experiences bradycardia or apnea. Attached with electrodes or belt around the infant's chest or stomach. Will provide a pulse oximetry reading. Internal cardiac pacemakers, implanted under skin to regulate heart rate on non-dominant side of the patient's chest. May include automated implanted defibrillator. Never place defibrillator paddles or pacing patches directly over the implanted device. This is almost rule number one when you guys are using the AED. Don't put your patches right over the pacemaker. Gather information about the type of cardiac pacemaker when obtaining history. Left ventricular assist devices. I'm not sure if you guys know this or not. They're LVADs. Take over function of either one or both heart ventricles. Typically used as a bridge to heart transplantation. May be difficult to palpate a pulse. Provide support measures in basic care. Use a caregiver as a resource. Be prepared to provide CPR. So these are very special patients. Basically, they do all the the heart pumping out of the left ventricle for the patient. Patient actually carries a little fanny pack around with batteries in it to help with the assist device. There's a lot of special rules regarding this patient, especially if you try and do CPR. They normally don't have a pulse. So this is one medical condition or one medical device that you guys should probably look up and be more familiar with. You probably won't run into these too many into your career. But there are 2 people in Monterey County that I believe have LVAD devices. So it's good to know what you can and cannot do with these patients. External defibrillator vest with built-in monitoring electrodes and defibrillation pads, worn by the patient under his or her clothing, attached to a monitor that provides alerts and delivers a shock. If patient is in cardiac arrest, vest should remain in place while you perform CPR. I've actually had one of these patients before. I walked into a room and it sounded like somebody had placed an AED already on the patient, and I realized that it was actually a patient's chest, or the external defibrillator vest, making all that noise because the patient was in a shockable rhythm. Central venous catheter with the tip placed in vena cava to provide venous access, used for many types of home care patients. Common locations: chest, upper arm, subclavicle area. So here's your central venous catheter. Sometimes it's if very sick patients, they need a lot of medications consistently or daily. The doctor will put in a central venous catheter for the patient because they don't want an IV in, because that could get infected. Or if patient has really bad veins, this is another reason why they would use a central venous catheter. They could also put shunts in as well for people who go through dialysis. They might have a shunt up in their chest area. Common problems: broken lines, infections around the lines, clotted lines, bleeding around the line or from the tubing attached to the line. Gastrostomy tubes placed into the stomach for patients who cannot ingest fluids, food, or medication by mouth, may be inserted through the nose or mouth into the stomach, may be placed surgically directly into the stomach through the abdominal wall. So here's a gastrostomy tube. May become dislodged. Immediately stop the flow of any fluids. Assess for signs or symptoms of bleeding into the stomach. Vague abdominal discomfort, nausea, vomiting, especially coffee ground emesis, is going to alert you to a GI bleed. And it's going to be an upper GI bleed, blood and emesis. Increased risk of aspiration. Always have suction readily available. Patients with difficulty breathing should be transported while sitting or lying on their right side with head elevated 30 degrees. Continue tube feeding unless the tube is dysfunctional, dislodged, or partially dislodged. Shunts for patients with chronic neurologic conditions. Tubes that drain excess cerebral spinal fluid. Fluid reservoir. Device beneath skin on one side of head. Behind the ear should alert you to the presence of a shunt. Types: ventricular peritoneum shunt, ventricular atrium shunt. Blocked infected shunt may cause changes in mental status and respiratory arrest. Infection may occur within 2 months of insertion. Signs of distress: high-pitched cry or bulging fontanelles, headache, projectile vomiting, altered mental status, irritability, fever, nausea. Difficulty with coordination, walking, or gait. Blurred vision, seizures, redness along shunt track, bradycardia, heart dysrhythmias. Vagus nerve stimulators. Treatment for seizures not controlled with medication, surgically implanted. Stimulate the vagus nerve to prevent seizure activity. Used in children older than 12 years, located under the patient's skin, about the size of a silver dollar. If you encounter a patient with this device, contact medical control or follow your local protocols. Colostomies, lleostomies, and urostomies. Colostomy or lleostomy, procedure that creates opening between the small or large intestine and the surface of the body. allows for elimination of waste products into a clear external bag or pouch, emptied or changed frequently. Assess for dehydration if the patient has been complaining of diarrhea or vomiting. Area around the stoma is prone to infection. Signs of infection: redness, warm skin around the stoma, tenderness of the colostomy or lleostomy site. Urostomy, surgical procedure that connects the urinary system to the surface of the skin. Allows urine to drain through a stoma in the abdominal wall. Contact medical control or follow local protocols for care of patient with colostomy, lleostomy, or urostomy bag. Patient assessment guidelines. Interaction with caregivers is an important part of the patient assessment process. They are experts on caring for these patients. Determine patient's normal baseline status before assessment. Ask what is differently today. Ask why you were called. What seems to be the problem? Is it a problem with the patient, or is it a problem with the machine? Home care occurs within home environment, represents a spectrum of populations: infants, older adults, chronic illnesses, developmental disabilities, services, delivering meals, cleaning, laundry, maintenance and physical therapy, personal care. EMS may be called to residents by home care provider. Obtain baseline health status and history from home care provider. Hospice care in terminally ill patients. Terminally ill may receive hospice care at a hospice facility or at home. Most have a DNR order or do not resuscitate. May have medical orders for scope of treatment. So when you guys run on these patients, anybody who is on hospice, they normally do not go to the hospital. They will take that patient off hospice once you do take them to the hospital. They're basically just comfort care until the patient passes away. Comfort care, palliative care, pain medications, improves quality of life before patient dies. Follow local protocol, patient's wishes, and legal documents. Bring documentation to the hospital. Always try and bring the DNR order with you. That way, in case something happens en route or something happens at the hospital, you have that piece of paper to give to the doctor, to the nurse, to protect yourself as well. Show compassion, understanding, and sensitivity. Ascertain the family's wishes regarding transport. Allow family member to accompany the patient. Follow local protocols for handling the death of a patient. Always ask family members on scene as well. If the patient does not have a DNR, what would you like us to do for the patient? Would you like us to start CPR en route if something happens? Always ask for a DPA too. Durable power of attorney. Basically, a patient has medical control over what happens with the patient, and they make the medical decisions regarding that patient. So it's good to ask about anybody on scene who might be a DPA. Poverty and homelessness. Unable to provide for basic needs. Disease prevention strategies are absent. Leads to increased probability of disease. Homeless population includes patients with mental illness or prior brain trauma, domestic violence victims, addicts, and impoverished families. Advocate for all patients. All healthcare facilities must provide assessment and treatment regardless of the patient's ability to pay. Become familiar with social services resources within your community. Okay. Which of the following is a developmental disorder characterized by impairment of social interaction? So B, autism is developmental disability characterized by impairment of social interaction. Cerebral palsy and spina bifida are physical disabilities. Down syndrome is characterized by a genetic chromosomal defect. Known risk factors for Down syndrome include C, increased maternal age, along with a family history of Down syndrome, are risk factors for Down syndrome. Which of the following may be difficult to perform on a patient with Down syndrome? Remember the physical characteristics of this patient. What's going to make it hard? to care for this patient in a particular setting. So D, intubation may be difficult because patients with Down syndrome often have large tongues and small oral and nasal cavities. Most patients with this disease also have hydrocephalus. You remember this is the one with the shunt in the patient's head because there's too much water and it's going to compress the brain. So C, most patients with spina bifida also have hydrocephalus, which requires the placement of a shunt. What does adult mnemonic help you to recognize? So A, the adult mnemonic helps you to recognize causes of airway obstruction in patients using technology assistance. What device is placed directly into the stomach to feed patients? So C, a gastrostomy tube is used to feed patients who cannot ingest fluids, food, or medication by mouth. What do vagal nerve stimulators do? So D, vagal nerve stimulators are an alternative treatment to medication for patients with seizures and keep seizures from occurring. An important part of the assessment process for a patient with special needs is to So A, interaction with the caregiver of a child or adult with special needs will be extremely important. They're trained to use or troubleshoot problems with medical equipment, and also how to interact with their with the person that they're caregiving for. Ask to know what their baseline is and what their likes and not likes are. What improves a patient's quality of life shortly before death? So C, comfort care is also called palliative care. Pain medication is provided during a patient's last day so he or she can enjoy time with family and friends. The EMTALA Act states that So B, the Emergency Medical Treatment and Active Labor Act requires all facilities to assess and treat patients regardless of their ability to pay for care.